Hello, Prof, and hello, classmates. This is Mary Shelley Esbiador, and I will be reporting on the evaluation part 2. To do the evaluation, one action must be selecting the monitoring and evaluation methods. There are two methods to collect evaluation data. First is qualitative methods that may include in depth interviews, focus groups, or anecdotal feedback mechanisms such as diaries and observational studies. It is by watching people in a natural setting without their awareness and observing their behavior. Number two is the quantitative methods that may include sales data, service statistics, or surveys. One must select a method that allows the program to best answer evaluation questions based on access to the intended population and resources. Consider also using participatory methods that make people living with and affected by part of the research process. Participatory research or methods provide ample opportunity for personal exchange, so allow adequate time for people to go at their own pace. The more complex the evaluation design is, the more expert assistance is needed to conduct the evaluation and interpret the results. An evaluation expert can be hired or assigned to help write questions that produce objective results. Sources of expertise include university faculty and graduate students for data collection and analysis, local businesses for staff and computer time, and health agencies, consultants, and organizations with evaluation expertise. Next is developing and pre-testing data collection instruments. To develop data collection instruments, ask the questions below. First is which data? The data collected should be directly related to the evaluation questions. For example, um, if members or the intended group needed to know more about a topic before behavior change can take place, ask knowledge related questions in the evaluation. Second is from whom. Evaluators should decide how many members of each group are required in the evaluation to measure change. There should be adequate resources to collect information from the number of people required. Different data collection instruments and methods for different groups may be necessary. And the third question to be asked is how. Assess available Assess available resources before deciding how to collect data. Are skilled interviewers accessible or can staff members be trained? Will self-reports from participants be used? And if so, do any confidentiality issues need to be addressed? Consider also whether participants will be comfortable with the data collection methods. Will they be willing and be able to fill out forms? Will they share personal information with interviewers? Or will the interviews and responses need to be translated? Methods of gathering information and interpreting results may vary depending on the culture and experience of the respondents. For example, Some people may not speak out in a group, such as a focus group. Some may be unwilling to provide answers they think will displease the interviewer. Others may be reluctant to provide information to a person from a different culture or social status over the telephone. And many may lack familiarity with printed questionnaires or have a limited ability to read the language or the questionnaire. And the third one is writing an evaluation report. An evaluation report should present the lessons learned in a clear format that can be easily digested by others who may be planning future advocacy, communication, and social mobility activities. Demonstrate accountability to employers, partners, and funding agencies. Third is provide evidence of the effectiveness of the ACSM interventions and activities. And last is create a formal record to serve as an institutional memory of what has been tried, which partners had strong skills or experience in specific areas, what problems were encountered, and what successes were achieved. To prepare an evaluation report, have staff with appropriate expertise analyze the outcome evaluation data and work closely with the evaluators to interpret the data and develop recommendations. The next topic is about indicators for monitoring and evaluation of advocacy and social mobilization programs. The examples is in this annex are excerpted and adopted from the Global Plan to Stop Tuberculosis. The number one indicator is the knowledge, based on knowledge. So it is called knowledge indicators. It is knowing that what TB is and the difference between TB, MDR TB, and XDR TB. Knowing how a person can get TB, knowing what kind of people are more likely to get TB or are most susceptible to TB, knowing how a person can prevent getting TB, knowing if and how a person with TB can be cured, knowing what a person could do to reduce his or her chances of a cure, knowing the cost of TB diagnosis and treatment in the country, and knowing how long TB treatment lasts. The next indicator is the attitude. How serious TB is considered to be a disease. When checking this, ask the question in relation to other diseases or provide a scale. How serious a problem TB is considered to be in a country or region. What a person would think if he or she were diagnosed with TB, what a person would do first, or how would they react upon receiving a TB diagnosis. What a person thinks about the effectiveness of TB treatment, and what a person thinks about the side effects or other problems related to TB treatment. The third one is the health seeking behavior indicators, where people usually go if they are sick or to treat a general health problem. How often people generally seek healthcare at a clinic or hospital. What a person would do if they thought they had symptoms of TB. What help a person would seek if they thought they had symptoms of TB, or if a person had a cough for more than 3 weeks, or if they were coughing up blood in their sputum, what would they do? If a person had symptoms of TB, at what point they would seek medical help? If a person had symptoms of TB, how long they would wait before seeking treatment, and who a person would talk about TB if they were diagnosed. And next is exposure to communication and mass media indicators, where people usually hear about TB and what sources of information can most effectively reach people with information on TB. How often people watch television, listen to radio, read newspapers, which they listen to or watch, read, and how often. Next is the stigma indicators, the feelings people have toward others they know who have TB or have had TB. If a person's close friend had TB, whether the relationship would change and how. In the community, how a person who has TB is regarded or treated, and so on. Next is the gender indicators. Women usually go to a healthcare facility alone. Men usually accompany their wives to visit a healthcare facility. Men or women are considered to be more likely to get TB, or men and women have the same risk. What a man in the community would do if his wife got TB, and the reaction in a family if a family member, prospective daughter in law, prospective son in law had TB. And the last one is the healthcare worker specific indicators. Education on TB or HIV is provided? If yes, how often? And so on. Yeah, the stage in their illness when people with TB usually begin seeking healthcare at the facility. How people react once they found out that they have TB, who people generally tell about their illness, and how a person who has a TB is usually regarded or treated. So those are examples of indicators for monitoring evaluation of advocacy and social mobilization programs. And that ends my report. And I have one guide question. It is, if you would evaluate an advocacy or social mobilization program, what are your own bases and when to consider it successful and why? Thank you for watching and listening to my report. Bye.